Hello everyone, and thank you so much for joining us for OSPF's November webinar, Enhancing Suicide Prevention Through Suicide Mortality Review. My name is Megan Rao, and I'm the Communications Coordinator for the Ohio Suicide Prevention Foundation. I have the privilege of hosting today's presentation, and I'm excited to welcome Kaylin Haggard and Kendra Barnes from the VA's National Office of Suicide Prevention. Before we get started, we'll take a minute for housekeeping details. After today's webinar, we'll send everyone a link to the post-webinar survey evaluation. This survey is required for those of you who want to earn CEs or a certificate of attendance. All certificates and a recording of today's webinar will be sent within the next 30 days. Now let's introduce you to today's speakers. Kaylin Haggard is a Community Engagement and Partnership Program Manager with the VA's National Office of Suicide Prevention. In this role, she provides technical assistance to Governor's Challenge teams in Ohio, Michigan, Tennessee, Kentucky, Indiana, Illinois, and Wisconsin, supporting their efforts to prevent suicide among veterans, service members, and their families. She also assists these teams in implementing suicide mortality review initiatives. With 18 years of social work experience in Ohio and 15 years of service at the Department of Veteran Affairs, Ms. Haggard brings extensive expertise and dedication to her work. Kendra Barnes is an MSW/LCSW who works as a Community Engagement and Partnership Program Manager in the VA's National Office of Suicide Prevention. She provides technical assistance and subject matter expertise to VA staff, community partners, Governor's Challenge, and suicide mortality review teams in Alaska, Washington State, Oregon, Idaho, California, Nevada, Hawaii, Guam, CNMI, and American Samoa. Kenner has worked in various social work, clinical, and supervisory roles ranging from direct practice to program management. She has experience in primary care, mental health interrogation, OEF, OIF, OND, mental health, primary care and spinal cord injury social work, behavioral health, interdisciplinary program, workplace violence prevention, and suicide prevention. Caitlin and Kendra, thank you both for presenting today, and we're ready whenever you are.
Thank you so much for having us today. I think we are going to roll right into our slides after that. Really, thank you, Megan, for that introduction. So we hope by the end of this presentation, you will be able to describe the public health role of suicide mortality review and suicide prevention, identify key mortality review milestones and current objectives in the Veterans Affairs and Substance Abuse and Mental Health Services Administration and within Ohio, and identify tools from the VA SAMHSA toolkit that might be useful for Ohio's suicide fatality review teams. And then at the end, we would love to discuss future initiatives and promising practices for other mortality review teams. So we're going to start with basically an overview of VA and SAMHSA's suicide mortality review efforts, and then move into more specifically tools that can be helpful. So I think one thing that we need to talk about is that the complexity of death by suicide requires both unique and flexible approaches to prevention. The urgency of what we have consistently high numbers and rates of suicide deaths require the application of practical solutions. So the magnitude of the national problem and the problem within individual states and territories and in communities requires a local response using proven methods. We have a broad range of literature that demonstrates what works to address a number of different factors that can lead to a suicidal crisis. And what really remains for us to do is to apply the broad range of proven approaches to the unique needs of the individual in crisis in the community that they reside in. By identifying these local circumstances, decision makers can customize actionable solutions and apply them at the local level in order to help solve this state, national, and very community-based problem. So it's a good thing for us to remember that within public health, suicide prevention remains the VA's top clinical priority. Over the past several years, we've taken a public health approach to suicide prevention. An essential part of this approach is defining the problem we're addressing. This will involve gaining a clearer understanding of suicide risk, including the contributing factors and warning signs at both the individual and the population levels, and then taking steps to address those risk factors while strengthening protective factors. So, as some of you may know, in 2018, the VA published a 10-year plan for suicide prevention. The goal is to align national strategic interventions for suicide prevention throughout the nation. This national strategy for preventing veteran suicide helps frame the work that we do. And in support of this ongoing work, it's really important for us to recognize and remember that suicide is complex with no single identified causal factor. We have to acknowledge that no one agency or one program or community or idea can be successful at prevention work alone. We all need to come together to reach veterans where they live and they thrive. And utilizing our combined efforts, resources, and talents, we can move in the right direction towards ending veteran suicide. As the VA has engaged in this work over the past several years, we've recognized that suicide prevention requires a public health approach, combining clinical and community-based interventions in the hopes of reaching all veterans where they live and connect. Our ultimate goal is helping veterans get connected to resources and care, especially during a crisis, but also working towards multiple upstream public health interventions with the intent of providing resources, support, and intervention before a crisis begins. Community-based interventions for suicide prevention serves as the unifying model for all community-based efforts to end veteran suicide within the VA. This is where our suicide mortality review efforts live. Usually connected to the state or territory governor's challenge teams, just as a point of information for those of you who may not know about the Governor's Challenge. It's a collaboration between VA and SAMHSA where state policymakers partner with local leaders to implement a comprehensive suicide prevention plan, which in many places now includes suicide mortality review. Other efforts within community-based interventions for suicide and prevention include Together with Veterans, which is focused on veteran-to-veteran coalition building and veteran leadership development for suicide prevention. And then many of you may be familiar with our community engagement and partnership coordinators. These are VA staff that are focused on community coalition building and enhanced capacity for outreach and education. Ultimately, while this coalition building may be facilitated by the VA, it is community-led and driven and focused on community interest in forming partnerships towards ending veteran suicide. Okay, now that we've talked about the VA's public health orientation to suicide prevention, let's focus in specifically on how suicide mortality review fits into that. So suicide mortality reviews, or I may use the terms SMRs or, as in Ohio, SFRs for suicide fatality review. They all refer to the same basic structure. They're systematic and comprehensive reviews of deaths that are intended to develop recommended strategies that will help prevent future deaths by suicide. Mortality reviews are conducted by SMR committees, or SMRCs, which access multiple sources of clinical and non-clinical information that provide a deeper understanding of circumstances that surround a death. The SMRCs then develop locally tailored recommendations for action to prevent similar deaths in the future. A community can really gather critical information and data to inform life-saving policy decisions and suicide prevention interventions through this collaborative, multidisciplinary analysis of a death by suicide. I think a great example of this is the Washington County, Oregon Suicide Fatality Review Team. They found that a number of pet owners who had recently lost stable housing were surrendering their healthy pets to the county animal shelter before they died by suicide. Within 2 months of receiving this information, the Washington County Suicide Prevention Council trained all staff and volunteers at every animal shelter in their county in suicide awareness and prevention, training those staff members and volunteers to understand the warning signs of someone in crisis, to ask them if they were considering taking their own life, and then referring them to the National Crisis Line if anyone said yes. So within 3 months of this training, staff in that county conducted interventions with 7 people who were surrendering their pets and who acknowledged that they were going to kill themselves after being asked or screened by staff. That's a win. That identification pushed those people who were at risk into a clinical treatment track that then may have kept them from dying by suicide. So such identification of community-specific risk factors allow teams to develop enhanced risk mitigation strategies. I think one thing it's really important to talk about when we talk about vitality review and identifying these local risk factors is that suicide is complex. And what may be a risk factor in one community may not be the same in another community. Going back to our example of people who were losing housing in Washington County, Oregon, and then being identified as higher risk by their suicide fatality review team. A community-based suicide mortality review team in Humboldt County, California, which is just down the coast, in approximately the same time as the Washington County team, found that recent evictions were one of the least frequent risk factors in their community suicide deaths. So what we know is that due to variations in resources and structures and communities, that death investigation across the nation really hasn't found a single method of suicide mortality review or developed one. So we know that there is a need and an importance to developing these community-specific mortality review processes. So let's take a minute to talk a little bit about the difference between psychological autopsy, which many of you in Ohio may be familiar with, and suicide mortality review. So a psychological autopsy can be described as the reconstruction of events that lead up to a death, and then the ascertainment of the circumstances of that death, including, if applicable, suicidal intent, and basically an in-depth exploration of other significant risk factors for suicide. Historically, psychological autopsies were originally designed to investigate, clarify, and help police inquiries into a mode of death. In most recent years, they've become more often utilized as a research tool for investigating risk factors for death by suicide. Psychological autopsy is a valuable tool for understanding the complex and really multidimensional nature of suicide. It involves the systematic and comprehensive exploration of the deceased person's life to determine their psychological, social, and environmental factors that may have contributed to their death by suicide. This method is particularly useful when the individual has not sought mental health treatment or when their medical history or mental health history is either incomplete or unavailable. It's also important to note that psychological autopsies can be incredibly resource intensive, requiring specifically trained and certified investigators and a significant amount of time and resources to complete interviews, record reviews, and complete reports. Overall, psychological autopsies are focused on the question of why the death by suicide happened. Conversely, suicide mortality review is a process that formalizes data collection after a suicide death. In essence, the SMR will conduct a case study and really analyze the identified deaths within a community. They collect data that can help identify common trends among those cases, and then their goal is to really report their findings in a clear, accessible, and really consistent manner. They make recommendations to key decision makers within the community. So a community-based SMRC will be able to identify risk and protective factors that are unique to a particular location or population, as opposed to just a particular person, as that's what happens in psychological autopsy, and then apply interventions to decrease community risk factors and increase community protective factors. Ultimately, the suicide mortality review process allows communities to track real-time trends, determine who in the community is at most at risk, and consider systemic changes that could potentially prevent future suicides. To really support SMR efforts, VA and SAMHSA have co-developed several resources supported by the SMVF, or Service Members, Veterans, and Family Members TA Center. One of these key resources is a toolkit, Promising Practices for Suicide and Mortality Review Committees. This toolkit provides communities with guidance and resources to develop and expand their committees. It's available on the SAMHSA SMR website and via this attached QR code. This toolkit should really be considered a basic introduction to the development, implementation, and application of an SMRC. Each section addresses communities in different stages of development. Section 1 is for communities who are exploring whether there is a need to establish an SMRC and what needs to be considered to make that determination within their community. Section 2 is for communities that have decided they want to establish an SMRC and covers what should be considered during the implementation stages. And Section 3 is for communities that may already have a form of mortality review being conducted in their community, or ones that have established an SMRC and are looking for ways to expand those efforts with considerations towards how do we make this sustainable. Each section includes key concepts for consideration, insights from communities with existing mortality review committees, and common barriers and practical solutions for each stage of development. Each section also includes resources, either online or included in the appendices, as well as key steps to consider. Thank you, Kaylin, for dropping that link. One of the other incredibly useful tools that is included in the toolkit is what we call the Critical Foundations Checklist. These are elements that are identified on the checklist as important foundational considerations that should exist or already be in development in a community prior to the establishment of a Suicide Mortality Review Committee. I think when you roll through them, you'll really understand why these pieces are considered critical and foundational in teams that are already engaged in this work in the field. So engagement with the Death Investigation Office is critical in the formation of an SMRC. You have to have organizational capacities to support the development and the sustainment of a mortality review committee within the community if your effort is going to be successful. And you really have to look at the key personnel identified. An example of this may be an epidemiologist. When you first think about mortality review, you may not be thinking about data collection and synthesis, but I guarantee you by the time you get to trying to make public health recommendations to your key decision makers, you're going to really want this person on your team. And another thing that you really need to consider is the engagement and approval of key community decision makers. That's going to look a little bit different depending on where you are and what your community, what community it is that you're supporting. But really, when you look at the key development and sustainment and really the efficacy of your mortality review committee, you have to have key personnel at the table. Membership, as we talked about, is incredibly important. So we've included recommended programs and community members that are normally engaged with effective mortality review committees. As I said just recently, one thing to keep in mind is that an SMRC is based on community composition and need. If you were to consider the breadth of the membership in mortality review committees that are currently engaged in work across the country, you would certainly find variance across those teams based on both local resources and then what the communities identified as their focus and their need. An important thing to keep in mind, though, when considering the membership of your mortality review committee is that it usually requires an agency that is chosen to be the backbone, who has the organizational capacity and resources to support the administrative functions that are required for SMRC work. This backbone agency works to identify and engage with needed community programs and members to support the ongoing work of a mortality review committee. I think one of the final things we want to talk about when we talk about just a structure of an SMRC is that the understanding that mortality review work is highly standardized, both in its processes and in its tools, because we want to maintain a high level of fidelity. Remember, the reason for these systemic and comprehensive reviews of deaths is the development of recommended strategies to prevent future deaths by suicide. Today, we're only going to look at one example of those tools, just to give you an idea of what's involved in that committee work process. So here you'll see the top of an example of a suicide fatality review intervention matrix. Teams utilizing tools identify possible protective factors for each risk factor identified from an individual case representing a death by suicide in their community. They then use aggregate data across multiple reviewed cases to identify possible places for effective public health interventions in their community. But those public health interventions have to be related to the risk and protective factors that most often arise in their reviews. Remember the story from earlier this morning, pets being surrendered to county animal shelters. That risk factor was very individual for Washington County, Oregon, and may not be replicated in other areas of the country, though conversely, it may. The SMRC was able to from Washington County, Oregon, was able to take that aggregate information that they identified on forms much like this and build a locally tailored, community-based public health intervention that was successfully implemented in their community. That kind of the outcome is the hope of all of our SMRCs. Okay. So we've spent quite a bit of time talking to you about the toolkit and some of the tools that are involved. And while the toolkit is an amazing resource, it is not the only supportive process out there for states, territories, communities, or tribal nations that are interested in developing an SMRC. Support from both the VA and SAMHSA culminated in the development of the Suicide Mortality Review Academy process. We began with one Academy cohort of 7 teams in 2023, and by the end of 2025, we expect that we'll have 39 states, territories, and tribal nations to be on this journey with us. The goal of the Mortality Review Academy is to support these teams in preparing for, developing, or enhancing a mortality review process in their own community. Technical assistance is provided both before, during, and after the Academy processes by both identified VA and SAMHSA staff, augmented by the SMVF TA Center. This is what a typical SMR Academy includes. So it's a 2.5-day in-person academy by a small 8 to 10 person team from the identified state, community, territory, or tribal nation. Each academy usually includes 6 to 8 teams, and built into the academy is a demonstration of a suicide mortality review meeting, 6 or a little bit more than 6 hours of team work sessions specifically to action plan for their own internal mortality review teams, and really specific sessions that focus on networking and collaboration with peers. And then I have listed some example breakout sessions from previous mortality review academies, just in case there's interest. Here's a visual representation of our 2023 and 2024 cohorts. Our 2025 cohorts begin in January and will be hopefully adding 14 additional states and territories to the map during the upcoming year. Our first SMR Academy participants that are attending that have confirmed are California, Georgia, Kentucky, Maine, the US Virgin Islands, and Wisconsin. And we're really excited to see them in January. So over the next few slides, we'll be reviewing a few tools that have been developed by the VA to help states, territories, and tribal nations that are either looking to engage or are currently engaged in SMRC work. We'll start with the creation of a release of information that's tailored specifically for the use of SMRC teams and the next of kins. If there's one thing that we've learned from the question and answer sessions at our mortality review academies and our communities of practice calls, It's that there will always be questions about data and data sharing. Good questions, great questions, not necessarily easy to answer questions. Throughout these experiences, we've recognized that one of the core steps in making the process of VA data accessible for suicide and mortality review committees and the families and next of kin that they work with was the need to create an authorization form that was specifically tailored for their use. Please note that we recognize this is one step, though we think it's a pretty big first step in the necessary iterations of creating data sharing processes with VA that is streamlined and effective for SMR teams in the field. One of the other really exciting developments is 2024 marks the first year of the VA Suicide Mortality Review Cooperative Agreements. These cooperative agreements support states, territories, and tribal nations in establishing, coordinating, and managing suicide mortality review committees to identify and characterize suicide deaths and support their capacity to develop and implement data-informed strategies to prevent suicide. For the states that already have established SMRCs, the cooperative agreement aims to establish and increase the capacities of those states, territories, and tribes to collect high-quality, uniform suicide death data, to expand their suicide death reviews, and ultimately to translate that data into suicide prevention actions at their community level. Applications for this funding opportunity closed in July 2024, and the VA is really proud to announce that we provided more than $4 million in cooperative agreements to 10 states and 2 territories this year. And the last kind of iteration of new work that we're engaged in is currently we're collaborating with the National Fatality Review Center to create an SMR case reporting system. The purpose of this new system is to collect, analyze, and report comprehensive fatality review data. The system will eventually allow users to enter case data, summarize findings, review team recommendations, access and download data, and create standardized reports, all at no cost to teams in the field. It's important to note that these reports can be used as an effective means of educating policymakers, agency staff, and the public about key factors and opportunities for suicide prevention in specific areas of concern to those individual communities. So this is not up and running yet, but it should be up and running soon. We are in the final testing phase, and we're really excited about this opportunity. So now that I've run through a ton of information about what's happening at the national level, I'd like to hand the presentation over to Kaylin Haggard to talk about what's happening in Ohio.
Thank you, Kenner. Appreciate it. It's my honor to present this incredible work that Ohio has accomplished in enhancing their statewide SMR efforts. While I'm not specifically a member of the interagency team that was driving this vital effort, I did have the privilege of supporting their work by providing the technical assistance through the Academy process that Kenner went over. So I'm just really glad to be able to present this information. Their dedication and their collaboration has been very impactful at a statewide level and also at a national level for suicide prevention strategies. Ohio was one of the inaugural participants in the VA SAMHSA SMR Academy in 2023. And as you can see, let me show you on this next slide. This is their journey. So they started out in 2023 by bringing an interagency team together. And then in early 2023, they conducted that environmental scan. And then in July of 2023, they attended the VA SAMHSA SMR Academy, and they developed their action plan. They continued to meet and implement this plan, and then they reconvened in August of 2024 to finalize their strategy and their implementation. The interagency team that came together for the academy process, they developed these overarching strategies to expand and support suicide mortality review efforts in Ohio. In Ohio, there were several counties that had active SMRs. So the strategies of this interagency team that came together was to support these already existing teams by developing a consistent process for SFR committees, education and awareness resources for the SFRs, and for newly developing committees, and then to highlight best practices around the state. The interagency team produced actionable goals to implement their strategies. They developed the Ohio SFR manual that was just released a couple of weeks ago. And I believe Kenner's going to drop a link to that in the chat. And that toolkit, similar to the VA SAMHSA one, has several tools for standardizing SFR boards that are specific to Ohio, and then how to integrate best practices. They also had a very successful suicide fatality review best practices summit last week in Columbus, Ohio, bringing SFRs across the state together to share and learn from one another. And I believe over 170 people participated at that event. The interagency team called upon several county SFRs to help them develop these best practices and the standardized education. The county SFRs that assist with the development of the SFR Summit that happened last week were Hancock, Huron, Montgomery, Franklin, and Muskingum counties. And then the counties that assisted with developing best practices and standardized education for integrating psychological autopsies into suicide fatality review committees were Lorain, Huron, Logan, Champaign, Muskingum, and Claremont counties. So I wanted to highlight this and give a special thanks to all those counties that participated in demonstration projects that inform the strategies and goals of the Ohio team. The Ohio team also had the vision to combine psychological autopsy investigations into suicide fatality review committees. As Kenner shared earlier, the difference between psychological autopsy and suicide mortality review, Ohio had a great idea to combine the two to get even more information. So they shared this information and their model with other states and territories at the VA SAMHSA SMR academies as a promising practice. And the Ohio team wanted really to build on this opportunity. And they decided they wanted to train additional PAIs that would integrate into SFR boards and committees across the state, allowing those committees to gain an additional and in-depth understanding into the psychosocial history of those who have died by suicide. Having more information to conduct an in-depth review ultimately just strengthens the recommendations from suicide fatality review boards for local and specific to the local community suicide prevention, intervention, and postvention initiatives. I wanted to share this map because when suicide fatality review boards review veteran deaths by suicide, it is essential to coordinate with VA suicide prevention teams located at every VA. This is a map of the VA facilities throughout Ohio. The larger bold text being the VA medical centers, and the smaller white text being VA community-based outpatient clinics, or CBOCs. Also note that there are those yellow triangles located in the northwest corner of Ohio. Those facilities do cover parts of Ohio, but they're connected to the Ann Arbor, Michigan VA. Excuse me. So as we've been going about this process for the last several years, the VA suicide prevention leadership from Ohio recognized that it isn't always simple to connect with the correct VA person when reporting a veteran death. So they developed these email addresses that suicide fatality review boards or community providers or coroners or medical examiners can use to contact the appropriate VA personnel at each VA facility. So this email goes directly to the suicide prevention teams at each facility, including their CBOCs. And then the suicide fatality review teams can use these emails to connect with the local VA to report deaths. This is also the best route to use to connect with local leadership of suicide prevention teams if requesting a VA representative on a suicide fatality review committee, or to determine how best to connect with the VA on data sharing using the next of kin form shared earlier in this presentation. And then I wanted to round out our presentation by sharing some suicide prevention resources from the VA. For the last several years, the VA has worked with the Ad Council to create our Don't Wait, Reach Out campaign. And this encourages veterans to seek help for life challenges before it becomes a crisis. Now in the fourth year, the campaign is expanding its messaging to engage loved ones of veterans, and new material has been developed for communities and for families. And I encourage you all to go to va.gov/reach for those materials. I'm sure many of you are familiar with 988. The Veterans Crisis Line is 988 and then press 1. And this connects to veterans in crisis and their families and friends with qualified caring VA responders through a confidential toll-free hotline or online chat or text. So all veterans have to do is call 988 and then press 1. Or they can send a text message to 838-255 to receive confidential crisis intervention and support. And that's 24 hours a day, 7 days a week, 365 days a year. I also wanted to share another online resource that has several veterans telling their stories about overcoming mental health challenges. It's called Make the Connection. And this is a resource that is good for veterans, families, friends, and others that's looking for information and solutions to issues affecting their lives. And you can find more information about Make the Connection at maketheconnection.net. And then, of course, we have our VA SAVE training. This training can be offered through your local VA suicide prevention team, and it's also available 24/7 through Psych Armor. Psych Armor Institute is an online training platform, and you can link to Psych Armor for free and search for the VA SAVE training. So the VA SAVE training is a video, or it's a training that helps equip those who interact with veterans to demonstrate care and support and compassion when talking with a veteran who could be at risk for suicide. So I just wanted to end by extending my heartfelt gratitude to the Ohio Interagency Team that came together for SMR efforts for their outstanding work on their suicide mortality review initiatives. And also a special thanks to the Ohio Suicide Prevention Foundation for graciously hosting us for this webinar. We are confident that advancing suicide mortality review efforts for all citizens will inherently include service members and veterans, paving the way for the development of best practices in local prevention, intervention, and postvention strategies. And we'll end with questions. Thank you.